Well, hello there, everyone. Thank you for joining us today. It is the top of the hour, so let's go ahead and get started. To all of you, our many guests across a number of time zones, good afternoon, or maybe it's good morning. My name is Emily Eberly, and I'm your technical host today. And on behalf of the Colorado Foundation for Medical Care and SACS Communications, I'm welcoming you. And following our presentation, we will be answering as many of your questions as time allows. By attending this webinar or by watching the View on Demand recording, you can earn one continuing education contact hour. And at the end of this webinar, you can obtain those continuing education credits by logging on to www.sacstesting.com/VH. Complete the post-test and evaluation form. Upon successful submission, you will be able to print your certificate of completion, and physicians, you'll be able to print a temporary certificate, and a final certificate will be mailed to you. This accredited module has been made possible through an unrestricted educational grant provided by Teleflex. And unless cited, the contents and conclusions of this course are solely those of the course provider. At this time, I would like to introduce you to Rita Larson, who will be your moderator today. Rita is a clinical specialist at Teleflex. Rita, it's certainly a pleasure working with you today, and I've enjoyed preparing for this event with you. Are you ready to get started?
Thank you, Emily. I'm very ready to get started. Good morning or afternoon, everyone. We do welcome you to this program. As Emily said, my name is Rita Larson. I do work for Teleflex, and I am a clinical specialist. Emily also stated following this presentation, we will entertain your questions, as many as possible, so you can type them all through the presentation, and I will be the one getting them to Dr. Wayne. The title of today's webinar is Preserving Vascular Real Estate in the Renal Patient. Speaking on this very important topic is Dr. Peter Wayne III. Dr. Wayne is currently an interventional radiologist with Surgical Care Associates in Louisville, Kentucky. Over the past several years, Dr. Wayne has spoken extensively at numerous medical meetings on vascular access in the renal patient, always with the goal to minimize complications. Most recently, he was a guest speaker at the American Diagnostic and Interventional Nephrology Annual Meeting on Preserving Vascular Real Estate. Some of that important information will be presented in today's talk. Dr. Wayne is very passionate about improving vascular access in the renal patient. We are looking forward to a very stimulating presentation. I wish to disclose the following relationships. Dr. Wayne is a consultant on the Speakers Bureau of Teleflex. He's a consultant on the Speakers Bureau of W.L. Gore and a consultant for Angio Advancements. The nurse planner for this session was Lisa Caffrey, with no conflicts of interest. At the conclusion of this webinar, participants will be able to describe a comprehensive plan to identify renal and pre-renal patients prior to the insertion of IV lines, discuss alternatives to placement of PICC and CVC lines for patients with advanced CKD, and list the evidence and current guidelines for the use of alternatives to PICC and CVCs in patients with advanced CKD. With this, I am very pleased to introduce to you Dr. Wayne. Dr. Wayne, go ahead.
Well, good afternoon, and possibly good morning to some of our listeners. Rita, thank you for that very warm introduction. Rita mentioned something at the very beginning about my passion for this particular area, and I'm a radiologist, so it doesn't encompass just radiology, but vascular surgery, nurse practitioners, nephrology nurses. It's a very widespread field. And I think that we have to become much more aware of first off, the increase in renal patients. Right now in the United States, there are roughly 400,000 patients who are receiving dialysis. By the most recent statistics from the CDC, that figure will reach close to 750,000 by 2019. So why is vessel health necessary? And is vessel health attainable in these patients? And do we need a comprehensive vascular assessment for every patient? The answer to that is really quite simple. We do. So who gets involved in this? It's not just going to be me. I need to have nurses who care for these patients. I need the physicians who are going to be requesting the venous access. We have to develop a vascular team made up of vascular surgeons, interventional radiologists, nephrologists, nephrology nurses, floor nurses. We have to develop a team that's going to approach this area with a lot of vigor and with a lot of interest. The nephrologist has to be part of the team because these are his patients. And of course, we need surgical intervention as well. This whole area began about 2008 when the Fistula First Breakthrough Initiative made their first recommendation. Basically, they recommended against PICC lines, and it was interesting the way in which it was phrased that this was going to involve patients who were in mid-stage kidney disease, otherwise known as stage 3. Stage 4, obviously stage 5 is on dialysis. But it was also picked up by the American Nephrology Nurses Association. They came very strong, they made a very strong point about using PICC lines in patients with chronic kidney disease really jeopardized that patient's ability for a permanent access later on in the future. The American Society of Diagnostic and Interventional Nephrology, primarily headed by Jeff Hoggard and Ted Saad and several others, made a very strong statement, which was also endorsed by the Association of Vascular Access Joint Practice Commission. And they felt very strongly that patients with an eGFR of less than 60, or basically those in stage 3, or if an eGFR was not available, then a serum creatinine of greater than 2 should undergo an expert vascular assessment. In other words, let's get this patient to a group of people who are going to make a decision as to the best vascular access route for that particular patient. The joint statement from the AVA and ASDN pretty much came up with very similar backing. They felt that we should develop a criteria to identify patients with CKD or chronic kidney disease. And for the patients who met this criteria, we need to implement a plan. We also need to educate the patient. And one step further was to take those patients in stage 3, 4, and 5 and give them some sort of identification. Let them, and it's becoming not just national, this is becoming worldwide. There are medical alert bracelets who were developed initially by the ANNA, which pretty much said, save the vein, no IV or no labs. In the research for this particular presentation, I also noticed that in British Columbia, they have a bracelet, and in the Society of Great Britain and Ireland, they also have developed a bracelet pretty much saying the same thing. So it's not just in the United States that we're being concerned about this. This is a global problem. If we go back to the initial KDOQI guidelines, pretty much, which started back in 1996 and then was revised in 2006, even in the 2006 guidelines, their statement was limiting the vascular access to patients in stage 4 and 5. We've learned over the past 8 years that this has to be more inclusive and to include stage 3. Please remember that stage 3 is broken down into 2 categories. There's A, which is the eGFR between 45 and 59, and B, which is between 30 and 44. The percentage of patients in those categories is pretty significant. There's roughly about 7.6 million people in the United States who are in stage 3, which dramatically drops to 0.4 million in stage 4 and 0.3 in stage 5. The most dramatic statement came from the Renal Network by a physician by the name of Tim Federer, who at the time of his statement was the chair of the Vascular Access Panel Advisory Panel for the Renal Network. And basically what he was saying is that the use of PICC lines in patients with chronic kidney disease jeopardizes the patient's ability for permanent vascular access, something that we've already heard. Again, getting back to stage 3, 4, and 5, that maintaining vessel integrity was essential to provide a future dialysis vascular access for these patients. We all know that, or at least at the end of this lecture, you'll understand why PICC lines can be so damaging. But the vein preservation idea and the position statement has also been endorsed by the American Nephrology Nurses Association and the Advanced Practice Nurses. But why such concern? Why are we going through all this? We do need PICC lines for IV therapy to infuse medications. Patients with bleeding disorders, we may need to do different sorts of medications for chronic diseases which require intermittent therapy, for nutrition, and sometimes oncologic treatments. But I think the staggering figure is that if we just go to 2003, 1 million PICC lines were placed in the United States in 2003. And in 10 years, that figure has jumped to 5 million. That's a pretty staggering number. We've got PICC lines in high volume, which are creating high risk and developing significant problems. Scott Truotola made a very strong statement and has repeated it many, many times since 1998. And his statement is basically what you're seeing. It is of paramount importance that CKD patients achieve early protection of their critical venous real estate. Well, what happens? The longer the catheter is in place, the more damage that's created. So we have to come up with other alternatives. We do know Fourier in 2003 pointed out that short-term catheter use isn't just a benign process. It can cause some endothelial denudation. Long-term catheters, we know, cause vein wall thickening. They increase the number of smooth muscle cells. And the focal catheter attachments to the vein wall with thrombus and collagen is also a potential problem. This has been supported strongly in the literature. And if you look at the dates, which really fascinated me when I was trying to get this together, Ducotman did an autopsy study back in 1985. He did 141 autopsy patients that had central catheters and found out that 32% had pericatheter thrombus in the brachiocephalic vein and in the SVC, and this had formed within 2 weeks after the catheter was inserted. Brambauer followed it in 1994 when he found out that, he reported the incidence of thrombus and stenosis in 8% of patients who received subclavian catheters and in 0.3% of patients who received IJV, internal jugular vein catheters. Hernandez followed up with his report in 1998 when he studied he used serial venographic studies to look at the effects of subclavian catheters and found out that 45% of these patients had stenosis and 7% had total thrombosis. In 2000, Allen used contrast venography at the time of initial PICC placement, and again when a subsequent PICC line was placed. He reported 23.3% developed venous thrombus, 38% with subsequent replacements, and the rate of thrombosis in the cephalic vein was 57%. Scott Truotola, also in 2000, studied 279 CVCs, and the conclusions are pretty obvious. 13% with thrombus in the subclavian and 3% with internal jugular veins. Abdullah followed a little bit later on, in roughly at about 2000, and he performed venograms at the time of PICC placement, and Gonsalves did the same thing, as did Yevslin. All of these researchers, very accomplished fellows, found out that PICC lines created a significant degree of damage to the peripheral veins, and something has to be done. This is a central catheter. It was actually it's a dialysis catheter that was in place and was not functioning properly. We ran a guide wire down through the black line through this black line as contrast. The catheter's been pulled back to the insertion site at the right internal jugular vein. Contrast is injected. And this basically is a fibrin sheath that has formed around that catheter. It should look more like this over on the right-hand side where there's a blush in the right atrium, but this long tube is basically where that catheter sat for a period of time. What's a fibrin sheath? It's made out of 4 specific proteins: fibrin, fibronectin, thrombospondin, and laminin. But why is that so important? Fibrin, basically, because it's a protein base, is like a petri dish. It creates adhesions for gram-positive bacteria, primarily Staph aureus. It's also very positive for Candida. Percival and Kite back in 2007 did a study. It's a very lengthy study. It's one of those reports one of these papers that you really don't want to read on a weekend because it'll ruin your weekend. Secondly, It's terribly long, and you don't want to do it lying down because getting to the last page is difficult, but it is a phenomenal article because of the things that they found out. They studied every single available catheter at the time in 2007. And the conclusions that they came up with were pretty significant. First off, fibrin can form around a catheter within 24 hours after its insertion. And secondly, there isn't a catheter that escapes that process. So if we've got PICC lines, if we've got subclavian catheters in place, there's a potential, a very strong potential for fibrin sheath to form around these catheters and the problems that these catheters then can lead to. I'm going to show you some examples of some of the damage that PICC lines and central catheters can create. This is, again, another study. This was that study I just showed you earlier. We put an angioplasty balloon down inside and inflated the balloon and broke up the fibrin sheath that was present within the right brachiocephalic vein and the superior vena cava. You can see that the progression. Here's a significant waist defect. That's how tight these fibrin sheaths can be. This is the balloon inflated. This is where the fibrin sheath was, and ultimately we're able to break that up. It becomes so important that when he basically inflates these balloons, once he has it inflated, he'll run this back and forth to make sure that he has dissolved the fibrin sheath. This is a patient who had a PICC line from the left side and also has a dialysis catheter on the right. They had tried to create a fistula within the within the left arm, and everything looks. This is a cephalic vein. It looks pretty good. Everything looks great, except when a patient also big, huge fibrin sheath. When we went centrally, the patient had a pretty edematous left arm, and when I ran the catheter down and injected, I realized that there was a complete occlusion of the brachiocephalic vein from a previous PICC line. Tried to get access from below, and the last slide is pretty impressive that my catheter is here. Here's the obstruction where the blue arrow is. There's the end of that's the end of the catheter coming in from the right femoral vein. I could not get across that obstruction. It's only a couple of millimeters, but it was just like concrete. I know several of the physicians out there may say, well, gee, I can get across that. I must have worked on this for probably the better part of an hour to try to get a wire across there and was unable to do that, trying all different types of wires, balloons, whatever it took. This has doomed that patient's access on that left side. So now we have to switch to another uninvolved arm and start all over again. It's another case of a PICC line from the right gone through the subclavian. You do see a lot of cephalic arch stenosis in patients who have had a fistula created, but this patient did have a documented previous PICC line in the right subclavian, the right cephalic vein, and in the process, it's developed significant stenosis at the insertion into the right axillary vein. I was able to open that up with a little balloon angioplasty, but that's going to recur. Now, granted, there's been a lot of good research in this particular area. Greg Miller has done some excellent research in the cephalic arch with stenting it, and Shemesh in Israel has done some very good work using fluencies. Both of those studies are very important because they give us an avenue of opening up these stenoses when they involve the cephalic arch. And the investigator in Toronto, his name is Dheeraj Rajan. This is a PICC line that had, a study of a patient who had a PICC line 2 years previous. They were getting ready to develop create a fistula on the right side, but because of some edema of the right extremity, they asked for a venographic study. And you can see where there's a significant stenosis, but unfortunately for this patient, it didn't just end there. There was a complete occlusion where the brachiocephalic vein met the right internal jugular vein. This is the anterior jugular arch. It goes over to the other side, so that flow was going from the left side into the superior vena cava because of a complete obstruction. With a lot of manipulation, we were able to get a wire across that area, able to finally get some contrast through and then dilate it. And the end result is that we were able to get some flow through there. I've learned over time that it's great to dilate it, but these areas have to be stented. They just don't stay open over the course of this patient's need for this particular central venous flow. If we're going to create a fistula in this right arm, this has to maintain itself, which also creates another problem because you've got the anterior aspect, the medial aspect of the clavicle sitting on top of the first rib, right where the subclavian vein floats. And I think I'm as religious as the next guy. But when I die, I've got to talk to the guy who put us together, because he really wasn't thinking about patients in renal failure when he decided to put the clavicle on top of the first rib and then put the subclavian vein to go through it. Those of us who work in this field realize that that has been an absolute nightmare. Some people get resection of the anterior aspect of their first ribs. There's all sorts of good research going on right now. No one has the perfect mousetrap to fix this problem, and it's due to the overutilization of peripheral veins with PICC lines and subclavian catheters. Another case, through the PICC line was in the brachial vein, and you can see it's pretty straightforward. I mean, you've got complete occlusion of the subclavian vein. Fortunately, we were able to open that one up, but these are long-term problems. This is another patient with a subclavian vein occlusion because of previous subclavian catheters. We're able to open that up. So what do we do? We're faced with this problem. How are we going to solve it? The CDC has made some recommendations as early as 2002, suggesting that central venous catheters less than 8 French should be used. The IJV is a great placement for central venous catheters using a subQ tunnel. And why? Simply because it reduces the incidence of bloodstream infection. So I think it's untenable for us to think that PICC lines are going to be totally outlawed from hospitals. I mean, we've already seen that 5 million PICC lines have been placed in 2013. But when can we use a PICC line? Patients who have terminal illnesses. They have short-term life expectancies. Patients with previously failed AV accesses. Patients with severe peripheral vascular disease with no vessel for construction. Michael Alon in Birmingham, Alabama, although not an interventionalist, is an excellent researcher, has found out that if the artery and the vein are not at least 2 millimeters in size, it carries an 86% failure rate. That's why vascular surgeons today are spending an incredible amount of time with vein mapping beforehand. They're looking at these structures not to waste the patient's time or their time, even though they love to create these small, I'm going to digress for women. I have the pleasure of working with 5 very gifted vascular surgeons. It's a success for them to do very, very small anastomoses. But in the patient with chronic kidney disease, if something's less than 2 millimeters, and we already know that it carries an 86% failure rate, there's no rhyme or reason to waste the time for that patient to proceed. I know that there are exceptions, but when you take the majority of patients, an 86% failure rate is a pretty high failure rate. So let's move on to something else. Let's come up with another alternative. The additional ways of achieving vein preservation is that we've got to choose an alternative way of getting that medication in. One of the things that we can do is to give the medication to that patient, particularly if they're on dialysis. We can give them the medication at the dialysis center while they're getting treatment. They're there 3 days a week, Monday, Wednesday, Friday, Tuesday, Thursday, Saturday. We also have to develop hospital policies to allow dialysis catheters to be used for other applications. I know that sounds like blasphemy to nurses who have been told never to use this, but I think that we have to consider other avenues. All clinical labs should report a GFR with the serum creatinine. It's an easy algorithm. It's an easy plug-in. When patients are admitted to the emergency room, blood is drawn. That's a no-brainer. When they're admitted to the ICU, blood is drawn. Hospitals should have available for the nursing staff a simple web page that they pop up, take the creatinine, get the eGFR, and make the assessment. Is this patient in renal failure? A lot of patients come to the hospital. We have no clue that they're maybe in stage 3, 4. We know if they're in stage 5, but we may not know whether they're in stage 3 or 4. PICC lines should be avoided if an eGFR is less than 30. We've already talked about that. Floor nurses should be able to place IVs overnight. And there are other methods that we can, and there should never be an emergency PICC line placed. The PICC team or the vascular team, the vascular assessment team, should assess 100% of all PICC line orders. And that assessment needs to look at the renal function, the patient's prior history, We need, years ago, when I was doing diagnostic radiology, one of the internists came up to me and said, asked me about these patients coming up with different differentials. And of course, as a radiologist, you always have 4 or 5 things, not just one. And a very astute internist turned to me one time and he said, I think it's about time I go see the patient. The same thing with this vascular assessment. Let's look at the arm. Let's look at the chest to see whether or not there are visible spider veins or collaterals. A lot of times the answer is right in front of us. All we have to do is look. We have to view the PICC line order as a vascular assessment, not an order. It's easy for nurses, and I understand that. I have to be very careful because my daughter's a nurse. And I have developed a much deeper concern for the nursing profession. But we have to be reasonable. Just because a doctor orders a PICC line doesn't necessarily mean that that's the best access route for that patient. We've got to be practical about this. This is 2014. We've got a lot of things available to us, so we just need to take a step back and say, okay, what's the best method to get fluids into this patient, whether it be urgent, whether it be emergent, or whether it's something that needs to be done long term. The Society of Interventional Radiology has been very, very strong and has a new number of recent guidelines, the most recent coming about that was written actually in 2010. And their assessment is to avoid PICC lines at all costs, particularly with patients who are in stage 3, 4, and 5. I alluded to this earlier, the pre-dialysis vascular access planning. This is a card that's given to patients who are over in Ireland and England. It says, please show this card when getting blood. Basically tells them not to draw blood from the side of the potential site for an access placement in the future. So what's our alternatives? We've got ports, we've got tunnel catheters. We also have interosseous devices. This seemed to be only pigeonholed into the emergency room. 2014 has been the advent of a lot of new technology. There are now interosseous devices that are very, very simple to use. And we also have much smaller bore catheters. We have to find an alternative central line access when we're thinking about long-term treatment. So let's come up with a bridge. Let's come up with something that can get us through the first 20 to 48 hours so that the vascular access team can sit around and decide, okay, let's decide what's going to be the best method to get what this patient needs, rather than just cavalierly throwing in a PICC line or a subclavian catheter. This is a picture of the IO device. It's called an EZ-IO. It is made by Teleflex. To my knowledge, it's the only automated interosseous device. I have seen it work. There's no rhyme or reason that I didn't know. To be fair, there are many other IO devices out on the market. This just happens to be, to me, a very simple one because it's battery driven, it's pretty simple to do, and you can get access pretty quickly. In the United States right now, IO, whether it be done by this device or any of the other available devices, can only be used for 24 hours. In Europe and Asia, they have a 72-hour limit, which allows them a little bit more time. I do know that the spokesperson for Teleflex, who is representing the IO device, is a doctor by the name of Chris De Valentis. And Chris has told me personally that they're pushing for the FDA to get a 72-hour extension. But at least we have 24 hours. So we've got a patient that has absolutely no peripheral veins. Let's try IO. You can get, and I have an example later on, I think that will really, the very first time I saw it just absolutely startled me, but there's an easy entry of fluids, medications, blood products. We can get everything we need through that IO catheter. It has a low complication rate. The Infusion Nurses Society considers IO insertion to require less skill than setting up a peripheral IV. It's fast, it's safe, it's easy, and it does the job for us. This is a chest X-ray. This is the IO device. It's been placed up in the humeral intermedullary space. And I want to show you what happens when they inject contrast through this. Now this is real time. This has not been delayed. This is just straight as it goes. Here we go. It reaches the central circulation probably less than 2 seconds. And this, I'm just going to let it run itself out. But so an IO approach is a very reasonable way of getting antibiotics into a patient, fluids, medications. I mean, you've seen it yourself. There is no rhyme or reason that I just got to show you this again. I just think this is absolutely phenomenal. There's the injection, gets into the brachial vein, and into the axillary subclavian. It's just right there. I mean, I think that this is a very reasonable approach to use on patients, even up on the floor. I'm going to make a very brash statement here. I think that floor nurses, not all floor nurses, but certainly those who are gifted enough to do IVs, should learn how to do IO. It's an access site. It's easy. This is a no-brainer to me. I have to be careful. I get a little carried away every once in a while. All right, what other alternatives do we have? We have a lot of central catheters, and there are many on the market. We've got the Hahn catheter, the Broviac. There's the Groschan. We've got the Hickman. I mean, there are a series of others. We also have a newer catheter in the market called the JACC. It's J-A-C-C. It's a jugular axillary subclavian. When this was first presented to me, I said, I like it, except I'm only concerned about the jugular approach, particularly if it's in a patient who has chronic kidney disease. I'm not interested in the axillary or the subclavian. That's what we're trying to avoid. Catheter comes in 3 sizes, 4.5, 5, and 6. You can tunnel this. You don't have to. It's designed right now to be a temporary catheter. Patients can leave the hospital with this. The benefit to this particular catheter is it is covered with, and inside and out with a substance called Chlorguard. It's chlorhexidine. It is antithrombotic and it's antibacterial. It is good for 30 days. You do not run out of the medications at 30 days. It does drop at a period of time, but for 30 days we've got a great access site for this particular catheter. And it avoids the axillary, the subclavian, peripheral. You can shove it in the external jugular. You can shove it in the internal jugular vein, which also brings up an issue. This particular package, and I have seen it, comes with everything you could possibly need. It's a full drape. You've got ultrasound probe covers. You've got everything you need to do this. And this is 2014. Placing, and I've been at this for 38 years, and before I would do a lot of blind sticks, but we now have advent of very easy to use, very accessible ultrasound. This package comes with an ultrasound probe cover. Let's be smart about this. Let's start using ultrasound. It's going to be less traumatic. You know exactly where your needle is going to go. You can also place it. You want to go as close to the clavicles, because if that catheter ultimately has to be changed for a tunnel catheter or for a dialysis catheter, you don't have to restick the neck. The lower you go, the better off that patient's going to be for changing a temporary to a permanent access. It's basically what this patient was discharged with this JACC catheter. But as I said, there are many others. So how do we continue to preserve these veins? We've got to communicate with nurses. Nurses need not be compelled to throw a PICC line in because the doctor ordered it. We've got to be practical. We've got to take a look at the patient. The doctor should thank the nurse for taking the creatinine, plugging it into a formula, and calling him and saying, "Doctor, I've got some," he knows his patients obviously better than all of us. But with the advent of hospitalists, a lot of these patients are brand new to hospitalists too. So any information that we can get with regard to the patient's renal function is going to be a benefit to the doctor, to the patient, and to everyone that's involved. An order is formed. We find out that the patient's in stage 3, so we call for an intravascular assessment. We need to standardize the way in which we do that. We've got to do much better IV education. We've got to increase the peripheral skills of our floor nurses, and we've got to do a better evaluation, particularly for stage 3, 4, and 5 of patients in chronic kidney disease. So what does this involve? It's got to be comprehensive. It has to be multidisciplinary. We can't just have a nurse and an interventionalist. We've got to have surgeons involved. We've got to have nephrologists involved. The family needs to be involved so that we can sit around and make the appropriate decision for that patient, because ultimately that decision that we make could be catastrophic to that patient down the road if they were to need a fistula or a shunt placed later on. Dorsal veins of the hand, easy thing to use. We should be able to we've all been in this situation. They just don't have any veins. Well, there are other things, and we've got to restrict the PICC line placement and subclavian catheter placement. Now, why? I think I've shown that there's a need out there. 700,000 patients is not a small number. We know that PICC lines now can damage veins. We've talked about where do we go. We've got a lot of external places other than, a lot of available places other than the subclavian and the axillary vein. You've got the internal jugular vein. You've got the external jugular vein. If you put an ultrasound probe over a patient who has an occluded internal jugular vein, oftentimes there's a vein out there that we can get access to. And none of us like putting catheters into the femoral vein because of, I don't care how clean we are, how hygienic we are, it's a bad place because of infection and perspiration and everything else that goes with it. We all know that. So yes, it's available. I think it's a last resort, but it certainly is better than damaging somebody's peripheral veins until we can decide what we're going to do. Putting something into the femoral vein for a 24-hour period of time is not going to create a problem, or should not create a problem. And we also have now some other alternatives. We've got IO, we've got these JAK catheters, and a lot of other central catheters that are available. So what are we going to do? We've got to change. It took, when I brought this to our hospital, it took us 3 years to get a vascular preservation program established. A lot of it was resistance from every avenue, whether it be PICC line nurses, intensivists, everybody seemed to object. Once we got everybody into a room and we started talking about the need, I think everybody finally realized, okay, there's a point to be made here. When we hire nurses, we've got to make sure that their competency in at least the initiation of peripheral IVs, not everybody's good at it, but there are some who are going to be very good at it. So the education has to be better. We've got to develop some sort of an algorithm so that when a patient hits the hospital, whether it's the ICU, ER, there's a formula that we follow. We have to make much better assessment. We've got to evaluate better. But now we also have the vascular tools that once those assessments are made, we can now sit down and make the appropriate decision for that patient and actually that patient's family. So there's a consideration for IV therapy. We've got to look at the renal function. We've got to look at what the patient had prior. We've also got to, use our heads. Take a look at the patient. Let's go and examine the patient before we make a decision. And we've got to consider the PICC line order as a vascular assessment, not a demand order. And I promise you, if you get resistance from your intensivists and from the physicians that are involved, you have my total support. I will back you 1,000%. Nursing has to be allowed to make these decisions. We can't do it without you. And I think the physicians have to understand that just because they wrote the order, that may not be the best thing for that patient. So the education to our physicians, especially the intensivists and the other members, and ER physicians, we've got to bring them on board as well. What do we need to do? Well, we need to make sure that we have a serum creatinine. We need to put into our programs at hospitals a formula so that the serum creatinine can be plugged in and they can come up with a reasonable EGFR. And again, we need to avoid PICC lines if the EGFR is less than 30. If the patient has end-stage renal disease that we know about, and even if the patient's a renal transplant patient, we certainly don't want to damage the transplanted kidney. Which, if there's any interventionalists or surgeons out there, when we assess these patients who have been transplanted and a contrast study has to be performed, we need to consider carbon dioxide as the contrast agent. Now, it can't be used in cardiac caths. We need to make sure we keep it out of the head. There's a whole list of things that we have to be cautious of. But I've been using carbon dioxide in my my contrast allergy patients and my patients who have had renal transplants. And it's very diagnostic. You can move forward with that. And I think everybody needs to know that there are other things other than iodinated contrast because it is so nephrotoxic. We know now not to use gadolinium because of NSF. So why continue to use contrast in a transplanted patient when we know that contrast is nephrotoxic? Let's be ecumenical. Let's become a little bit more worldly. Let's start using CO2. The floor nurses need to know how to place peripheral IVs and understand that there's no such thing as an emergency PICC line. We need to consider alternatives. And we also have to remember the patient. I want to thank Rita and the entire staff and thank all of you for listening. I know I get a little bit excited about this because it is, I think, a very important part of what we're doing in 2014 and the future. I want to thank you for your attention. I hope you'd enjoyed it. I hope you learned a little bit. And thank you for being so, it's kind of hard when you can't see an audience, but I want to thank everybody who's out there. Appreciate it.
So, Dr. Wayne, that was great. We appreciated all the information. We appreciate your passion with which you speak. And as you were speaking, I have many, many great questions for you. So I want to start with one. You mentioned that using a patient's hemodialysis catheter for routine IV draws, for the administration of drugs, etc., we as nurses have always been instructed and forbidden, actually, not to touch a hemodialysis catheter for anything other than dialysis. How is this dramatic change in patient care going to be achieved?
I think we have to go back to the beginning. The nurses who are already out practicing, it's been something that's been just drilled into at least the nurses that I've spoken to when I bring this up, they kind of look at me like I have three heads. I think we have to go back to the nursing schools and we have to educate them as well that, yes, there are times and places where a central catheter for dialysis can be used as a peripheral line. When we think about it, it's been done under sterile technique. If it's a tunneled catheter, it's sort of encased. You're using the external ports. And as I mentioned earlier, I think if we follow the care of good sterile technique, as they do in the dialysis as they do in the dialysis centers, it certainly can be duplicated on the floor, probably even better. So I don't think that we need to shy away from that. I think we just need to start educating. We need to convince the nephrologists, the nephrology nurses who have been also told that, I don't want you touching this catheter, that there is a time and a place when that may be a necessary IV route. And I think once we get that education across, we need to do it at medical staff meetings, we need to do it at nursing meetings, so that everybody understands that, yes, there are times under proper circumstances when we can use these lines. I mentioned using peripheral IVs, for peripheral blood draws. I think that there are times, rather than whacking away at this patient, you've got a line, if you follow, yes, it's going to take a little bit more time, but you've got a direct line to the central system. There's no reason that we can't use these. I hope that answers the question.
Yes, thank you very much. I have several questions. Denise asks, if a patient with a hemodialysis catheter developed a clot in the subclavian on one side, what are the chances of a clot reoccurring on the other?
It all depends on why, what was the cause for the thrombus in the subclavian vein. If the clot formed because of the dialysis catheter, which I think is what's being implied, the best thing to do would be to probably treat that with heparin and to monitor it and make sure that it does eventually dissolve. I guess that there are occasions when you could use direct TPA. The incidence of that developing on the opposite side would really depend somewhat on the anatomy. There may have been some narrowing of the brachiocephalic vein, and the catheter from the left side that's in that brachiocephalic vein may have occluded the flow. On the other side, there may be a wide open brachiocephalic vein. So I think we'd have to do an assessment to take a look at what the venous structures look like to see whether or not there's patency. And was the clot on the left side of the dialysis catheter, was that something that was created because of anatomic variation, pathology? So I don't know that I could directly say, sure, it will form on the other side. I think we'd have to take a look at the anatomy on the other side and decide whether or not there's a potential. So not necessarily would that be, I apologize for that, I don't know that I could definitely say that it would. I think we just have to assess it and then make a decision from there.
Okay, good. Crystal asks, how safe is it for IR to go in and break up an occlusion?
In the central system, I think is what she's referring to.
Yes.
We do it all the time. We have narrowings of the superior vena cava, the right brachiocephalic vein, and we go in and dilate those routinely. The biggest risk is obviously rupture. We don't know what that stenosis was caused from. We don't know how long it's been there. We don't know how rigid it is, what the fibrotic tissue is around it. But I think if you use a sequential pattern, if you go in and you first off, if it's occluded, you want to get access, you want to get it open. So you will use first to get a wire across. Once you get your wire across, then you can put a balloon across there, and you start with maybe a 5 millimeter or 6 millimeter balloon, and at least get flow going through there. And once you do that, then you can sequentially increase the size. You can go from a 6 to an 8 to a 10, depending on which particular vessel. In my experience, I think if you could take a subclavian to a 12 millimeter size, you're pretty much going to establish good flow. I think anything will flow through a 10. The subclavian and the brachiocephalics respond a little bit better to a 12 millimeter dilatation, but not every person can tolerate a 12 millimeter balloon. So I think you have to use some judgment. You have to do and once we get flow going through there, which is basically the ultimate goal, it can be done. I think rupture is always anybody's concern. And I think you need to have, those of us who are doing it, we also have to make sure that we have the appropriate equipment in the facility that we're using, that if that were to occur, we can correct it. John Ross has written extensively on it, Dhiraj Rajan has, and we need to have stents in place that if you do rupture something like that, you can correct it with a stent placement and not create any additional problem for that patient.
Okay, good. Thank you. Tracy asks, is the rate of obstruction in stenosis the same regardless of insertion site of the PICC line? And she means basilic versus cephalic versus brachial.
From what I was able to tell, I think that there's an increased incidence of stenosis and thrombus within the cephalic vein. If you looked at some of the studies, it went up to as high as 57%. But I've read other articles that it's even higher than that. So the cephalic vein, I think, because it's anatomic course, when the cephalic vein goes up toward the shoulder, it has to make an arc to dump into the axillary vein. It has to go through the clavopectoral fascia. It has to go through the deltopectoral groove. So there's a lot of anatomic structures that vein has to go through. Two articles that were written earlier on by Asif and one by Rajan, where they studied the cephalic arch, they found out that fistulas that were created above the elbow joint were those who were created above the elbow joint using the cephalic vein, then anywhere from 38 to 40% of patients would develop stenosis of the cephalic arch. The same thing goes true, I think, with PICC lines. You've got basically a foreign body that's banging around on the inside of the cephalic arch, which also has a potential for narrowing because of just its anatomic course. So I think the incidence of thrombus and stenosis within the cephalic vein is much greater than within the axillary or the brachial. It does occur in those structures, but it's a little bit higher in the cephalic vein. And the subclavian and the axillary vein are pretty much equivocal. I think that it ranges anywhere from about 22 to 40%.
Okay, thank you. These are great questions, everyone. Keep them coming. And Matt asks, is it okay to place a PICC in an arm that has a failed fistula?
It's a great question. My only hesitation, first I would want to know why there was the failed fistula. Did the fistula fail on that side because of central vein stenosis? If so, then you might even have trouble getting your PICC line in on that side. If the fistula failed because of poor arterial inflow, and you still have some acceptable veins, the likelihood of creating a fistula on that side or a shunt on that side would be pretty remote. And the reason I'm saying that is that sometimes, even though a fistula has failed on the side, whether it be right side or left side, you may have the ability to put a shunt in. A shunt and graft are the same. We interchange those a lot. An EPTFE graft from the artery to one of the more central veins. If you put a PICC line in, you still run the risk of damaging the subclavian and the brachiocephalic vein. So if the central veins are open and you have a failed fistula, that arm still might be a very viable source for a shunt or a graft. So I would be a little bit cautious. I'd want to know why that fistula failed. If, in fact, there was any central vein stenosis, I'd want to do a vein mapping beforehand to make sure that there's good flow centrally. If there is, I think I would avoid it like the plague. If there's a central vein stenosis, I think putting the PICC line, as I mentioned earlier, you might have a difficult time getting it in.
Okay, thank you. Deborah gives her compliments, so no question here, but she just wants to, she states this is very helpful information, and she will be including this in her work with the PICU CLABSI Collaborative. So I just wanted to give you a compliment as well. And Molly asks a good question. Can you explain more about what you mean by collateral veins when assessing the chest?
If you have a central vein stenosis, whether it be the brachiocephalic or the subclavian, blood's got to get to the heart somehow. And so it's going to, you and I have a plethora of veins in our chest, a lot of which are pretty dormant. They have, as we've developed, the normal circulation has taken over. In other words, on the right side, well, both sides, we have brachial to axillary to subclavian to brachiocephalic back to the superior vena cava. If we obstruct any one of those spots, a lot of these embryological veins are all of a sudden going to start resurrecting themselves, because we've got to make sure that we get blood back to the right atrium. So some of these vessels are very superficial, and you can actually see them there. They can be spider veins, or they can be pretty tortuous veins over the upper chest, either on the ipsilateral side or the same side as the obstruction. Sometimes even I've seen them on the opposite side. So the collateral veins are veins that develop because of a central obstruction. And they develop because, as I said, we've got to get blood back to the right atrium. So it will use whatever avenue it can. I showed you one case of the anterior jugular arch where it crossed all the way over to the left side. You normally, if you're doing a venogram of the upper extremities, you're not going to see the anterior jugular arch because it's not necessary. We don't need it. We have enough good vascular flow going centrally. You start obstructing that, and all of a sudden that's going to become a very prominent primary vein to get blood either to the opposite side or find another larger vein on the ipsilateral side to get blood back to that right atrium. So the collateral veins are just veins that are present. We normally don't see them until there's a need, and then they become dilated because of the need to get blood back to the heart.
Okay, thank you. Sandra asks, are there any problems with fibrin sheath formation with ports?
Oh, always. In fact, we do, I shouldn't say some. We are just 2 floors below a very large oncology group, and we are doing metaport studies all the time. And fibrin sheath forms on port catheters, and the use of CathFlow or TPA only cleans the inside of your catheter, of your port. Oftentimes, in fact, I did one just last week where we had a significant fibrin sheath that had formed around the distal end of the catheter. The catheter was that was the tip that was located more centrally, not near the reservoir. And around it was this significant this fibrin sheath. I'd spoken to the oncologist, I had spoken to the family, and we were going to go from the common femoral vein and we were going to strip it. But unfortunately, the patient, because it was in fact, this was one of the cases where this woman had this thing placed a week prior to the development of this. Pretty significant fibrin sheath, was really not functioning. But unfortunately, that next morning, she was admitted to the emergency room with a very, very high fever. And they ended up having to take the port out because catheters are foreign bodies, and that was probably the site for infection. But yes, they can form on ports without any problem at all, and can be a nuisance to oncology nurses when they're trying to draw or trying to infuse the appropriate drugs or to get blood samples.
Okay. A couple more compliments. Diane is very excited. She says, excellent presentation. We fight this fight every day. So Debbie also asks, how soon after a PICC placement can a DVT form?
Oh, DVTs can form within hours. It doesn't take much time at all. I mean, they happen very rapidly. I think one of the things that has to be concerned is with a patient who has developed a thrombus from a PICC line. The PICC line's pulled, and the order comes in, several months later for another PICC line. Has that thrombus dissolved? We need to do some ultrasound assessment to see whether or not there's another vein. If that thrombus is formed in the subclavian, whether we go from the axillary or the brachial, the cephalic, it really doesn't matter. You're going to have to go through that clot to get your PICC line in. I think we need to be a little bit more astute in our assessment of these particular patients. One of Rita, just before one of the girls was talking about the fight that she has, I just want to give you one encouragement. To start your vascular access program at your hospital, if you don't already have one that's up and running and functioning properly and everything, you've got to go and you've got to get the support of your nursing service. That's paramount. You also have to have the infusion group, whether it be the PICC team or the infusion team or the IV team, whatever they're called. That has to be on board. But then you also need to go to the nephrologists. Whichever nephrologists are working in your hospital, once you get their support, you're on a roll. Interventional radiology should follow suit. And I really do feel that vascular surgery is going to be very involved, because there are cases when it's outside the scope of interventional radiology, it's outside the scope of nursing, it's got to go to the vascular surgeons. So that particular nidus of people have to be involved in making that decision. You know, when they meet, who makes the ultimate decision? You know, it's a team. It's not going to be one person. You know, everybody has strong personalities. It's not going to be one person that's going to make the decision. They're going to take a look at, they're going to assess the patient, they're going to look at all the parameters that we brought up earlier, and they're going to say, okay, collaboratively, we feel that this is the best way for this patient to go. It's all going to work itself out in the end. This is not a turf battle. This is a comprehensive assessment of the patient. You've got some very good people involved in your group who understand what's going on, who understand renal disease, and even, you know, if you have a nephrology nurse on staff, that person needs to be involved. They're the ones that deal with these problems. So, you know, having all that, I think, involved is really going to help spearhead your organization. I think it's something that you need to really strongly consider. Every hospital should have one.
Thank you. We're almost, or we've got about 1 minute left, so I'm
Excuse
going
me, Rita?
Yes, go ahead.
Let's go over by 5 minutes. We have many, many questions. It's okay to go over 5.
Okay. Alice asks, do you support vascular access nurses placing IJ catheters for CKD patients?
I'm sorry, can you read that one more time, please?
Yes. Do you support vascular access nurses placing IJ catheters for CKD patients?
My only hesitation is I'm not sure I don't know enough about vascular access nurses to know what their training is. So I don't have one in my group. I have nurse practitioners, but they're not involved in the technical side. They're more in the diagnostic side. I think if someone is properly trained, I don't object to a nurse. I don't object to nurses using I/O. And if I'm not going to object to a nurse putting in an I/O device, I'm surely not going to object to a nurse doing a jugular line. But like all of us who are, you know, and I keep referring to 2014 because of modern medicine and things, but we have to face the facts. We've got the technology out there to make our job easier. For us not to use the available equipment is ludicrous. You know, the old standard, I've been at this a long time, but I've got guys who are my age who just won't they won't put a line in using ultrasound because they can do it. Well, you know, okay, come on. You know, you can do a better job if you use ultrasound. I think if the vascular access nurses are trained properly, they know how the proper use of ultrasound, which I'm sure they do, I don't object to that at all. First off, we're going to need it because the manpower shortage in the future among physicians is going to be dramatic. I think there's a strong role for nurses to be practitioners, whether they be the technical side, the diagnostic side, it makes no difference to me. But I think if we train them properly, I don't have a problem with that at all. I want them to be able to do it all because they're going to make my job easier.
Good. Dave asks, if you see collateral veins on the chest, is that a contraindication for PICCs?
Well, it certainly should raise your antenna and make you suspicious of something going on. People just don't walk around with collateral veins, engorged collateral veins over the chest. You know, in my experience, it usually indicates something's going on. There's something that's happening in deep centrally to create this appearance. So I think we just have to assess it and decide, okay, let's take a look and figure out why this patient has these things. Do we need a contrast study? Do we need to take a look at what the veins look like and the flow? And that may fall over to IR. Again, because now we have some alternatives for placement, it's not a rushed decision. We can sit back, we can talk to the people and say, okay, IR, would you mind, shooting some contrast in this patient? Okay, the patient's in renal failure. Use CO2. There's an actual book on CO2 angiography. It's written by Hawkins and Cho. It covers everything under the sun. Cho's at the University of Michigan. He's done almost 3,000 cases using carbon dioxide. So there are avenues to make that diagnosis without being detrimental to the patient. But certainly, the presence of these collateral vessels should raise everybody's index of suspicion and say, okay, let's not just jump into this. Let's assess this first. Before you diagnose somebody as being crazy, you make sure that there's nothing pathologic going on. If everything that you've tried to prove pathologically is normal, then you can turn to the patient and say, okay, we've got a mental problem here we've got to deal with. But in medicine, the old axiom is, let's figure out what may be the cause for that behavior. The same thing here. Those veins are behaving abnormally. Let's look at the pathology that might be causing it. Maybe it's just the way the person was put together. But by and large, there usually, I shouldn't say has to be, but there usually is an anatomic pathologic variation that's created that problem. And I think we just have to be a little bit more astute about our diagnoses on these.
Okay. A little bit more along that line, but can you describe very briefly the process for using CO2 for contrast replacement for CT?
Sure, I can. You've asked me to be brief, and I don't think I've done anything in my life that's been brief. But anyway, CO2 is odorless. It's cheap. Before we use carbon dioxide, we would use the huge tanks of CO2. What we found out over the past several years is that most of the CO2 in those large containers is contaminated. Usually there are old canisters that have been sitting around. There's rust on the inside. There's debris. You and I don't see that because we don't see the inside of them. We're just delivering the CO2. But we're going to do an assessment of the vein. You're obviously going to access the vein. When we use it in our assessment of patients with fistulas and shunts, you access it just like you would if you're going to use contrast. You basically have to purge the system. In other words, you have to get all the saline out of the tubing that you're going to use as your delivery. You fill that up with CO2, and then if you're going to do a fistulogram or a shuntogram, you take your images while you're injecting the CO2. Two major precautions. CO2 you want to keep out of the head. You don't want it getting into the the nervous system circulation, and you want to keep it out of the coronary arteries. The only drawback to the coronary arteries is that when you're using CO2, you and I really don't know whether that patient might have an ASD or a VSD defect. If they do, that would be a contraindication. But it's such a low percentage that the likelihood of that happening is pretty remote. Excuse me. I'm sorry. When you are giving it in the vein and you're injecting, you want to make sure that you don't reflux it back into the feeding artery, whether it be the brachial artery or the radial artery, because if the CO2 were to ascend up the artery, up the brachial artery, it's obviously going to go into the axillary of the subclavian, and the first branch of the subclavian is the vertebral. So there's a small percentage of, and it's written in the literature, I've not had this happen to me, but I have refluxed it into the artery only up to about the armpit, but it does make you aware that when you're injecting CO2, you have to be a little bit cautious about refluxing into the artery. The most important things about CO2, it replaces blood. It pushes blood out of the way. That's how you get the image. Contrast mixes with blood. So since you are injecting, and there's no limit to the amount, you just have to wait between 60 and 90 seconds between each injection. You can give 40, you give 30 cc's, you give 20 cc's. The only problem is that you've got to wait 60 to 90 seconds after to allow that CO2, which is going to get into the pulmonary circulation, into the lung fields, to be blown off. If you rapidly inject CO2, in other words, if you give it too quickly, you give a bolus of 40, and then 5 seconds later you give another bolus of 40, you run the risk of developing a CO2 vapor lock in the right atrium. So after each injection, it does lengthen your procedure a little bit because you've got to wait I always wait 90 seconds. I'm pretty religious about that. But if you wait, it allows the patient time to blow that off. But again, having said that, you've got to make sure the patient doesn't suffer from severe COPD because their pulmonary function is going to be compromised. So you might have to wait even a little bit longer to use it on a CO2 patient. And you might want to use 40 cc's. You might want to drop it down to maybe 20 or 25. You'll get good images, very diagnostic images. It blows off. There's no consequence to it. It is not nephrotoxic. It's a very simple agent to use. I think it's invaluable in what we're doing, especially with CKD patients. I hope that answers this question.
That's a great answer. And we appreciate all of your time, all of your information. We have many, many questions, and we're already almost 10 minutes over our time. So with this, we just want to say thank you for this valuable information. It's been great, and I turn it back over to Emily.
Well, thank you, Rita. And Doctor, that was a wow presentation. That was just awesome. No, I could have listened to you for another hour, and I'm sure many of our attendees were glad that we went over a few minutes. But it is time. We have to let people go on with the rest of their day. I want to thank you sincerely, Dr. Wayne. It was a pleasure to work with you and learn from you. And Rita, thank you so much for moderating and handling all these questions. There were quite a few, and I'm sure you were real busy.
Emily, I have one question.
Yes.
I mean, if they have questions, they can email me. Yeah, it's a very simple one. It's just pwayne, P-W-A-Y-N-E, at surgicalcare, surgicalcare.com.
Thank you, Doctor. That's very generous of you. And I want to thank you again, Rita, for being such a great moderator. And last but definitely not least, I want to thank each and every one of you, our members of the audience today, for your time and your very thoughtful attention. And with that, thanks for coming today. Everybody, take care, and we'll see you next time. Bye for now.